Um, Second most common cancer in men, prostate's the most common cancer. Second most common cancer in women, lung cancer, after breast. But look at the cause of death from cancer. The leading cause of death from cancer in both men and women profoundly is lung cancer. We have all these, let me get on my high horse here. We have all these programs, pink ribbons, breast cancer, but the number one cause of death from cancer, profoundly twice as many times, is lung cancer. Okay, but no one ever talks about it. As far as having a little black ribbon or something, we should. Yeah. More people die from lung cancer than colon, breast, and prostate combined. Yes. Hold on to that thought. Okay. Looking at this is 2010, but basically you're still looking at a couple 100,000 new cases with about 150,000 deaths per year. Can be of any age. It's strongly associated with smoking, both first-hand, second-hand. Did you ever hear of third-hand smoke? Did we talk about that on the surfaces? Also associated with asbestos and radon. You take a look at, these are the other causes of cancer: colon and rectum, prostate, stomach cancer. Those are all going down. Well, lung is too, but it's a whole lot higher to start with. So, and this is for females. That's there. And this is the incidence around the United States. Gee, it's kind of funny that, isn't this kind of like tobacco country? What it is a progressive, uncontrolled multiplication of abnormal cells. These abnormal cells are known as a neoplasm or tumor. They can be localized, that they're in one area of the lung, which is better because it can be removed. It can be invasive, where it's actually not only into the airway itself, but it also can be into the blood vessels. They can be benign or they can be malignant. Benign meaning that they aren't harmful necessarily unless they become invasive. The suffix OMA means a benign tumor, so a fibroma or a myoma or a lipoma or neuroma means that it's a benign tumor. Carcinoma means it's malignant, or a sarcoma means it's a highly malignant that you end up having. Benign, again, doesn't normally cause problems unless it interferes with the organ function. It's going to invade and push aside normal tissue. It's usually slow growth, and it's usually easily removed surgically. Malignant, on the other hand, are very disorganized and a very rapid growth pattern compared to the others. They invade normal tissues, and they basically can lead to destruction of those surrounding area with ulceration, cavity formation, and just generalized mess. The term metastatic refers to the primary tumor in one portion of the body that is now found in secondary areas, including the lymphatics, which is one of the ways that typically they end up being the cancer spreads. Bronchogenic carcinoma or lung cancer is the most common in the tracheobronchial tree. And as it gets larger, it occupies more and more of the lung tissue itself, to the extent that you end up getting obstruction, atelectasis, and if it involves the penetration of the vessels, that's where you'll end up getting hemoptysis occurring. 4 major types of bronchogenic cancer. There's actually more than these. These are the primary ones that I'm going to have you kind of familiarize yourself with. They're divided into 2 general groups. One is non-small cell lung cancer, and one is small cell lung cancer. Of this non-small cell, meaning they're big, there's the squamous, adenocarcinoma, and large cell carcinoma. The small cell, there's only one type, and it's called oat cell, and as we'll find out, that's the bad one. Squamous, about a third of the cases, they originate from the basal cells of the bronchial epithelium. if they have metastasis, it's late in the course. Doubling time's about 100 days, and they're usually in the large airways, and it's directly linked to smoking. So if you think about how cigarette smoke is when it's inhaled, the bifurcations that you're going to end up having these tumors grow. And there you can end up seeing the growth of the tumor in one of the larger airways. It's more centrally located. And here's just another wonderful picture on autopsy. Adenocarcinomas, a little bit more, but roughly in the same general area. It goes back and forth between squamous and adenocarcinoma as far as which one is the more common on a year-to-year basis. So, yeah. But again, 3 years from now when I'll give a selection, will probably be back the other way because they kind of flip-flop back and forth. A little bit longer of a doubling time. These are formed from the mucus lens within the tracheobronchial tree and are usually found more in the periphery. Okay. So here we end up with a graphical scene. You can see how that contrasted with the the other one, squamous cell. And there is a periphery, cauliflower growing in your lung. Large cell is a little bit less common. This is found both in the periphery and the central. It's a very rapid growth rate. Has a tendency to have metastasis earlier on in its course, and this is where you find a lot of these. So here we end up having, in this case, they're just large cells. And again, this is how histologically they would, from a biopsy, be able to identify what type of cancer it is. It's ugly. The worst of them is small cells or oat cell cancer. It's also less common, but it arises from Kuczynski-type cells, for what that's worth. They're usually near the hilum, and they have a very, very rapid growth rate. And usually they're already metastasized by the time they're diagnosed, and they're go-to everywhere else in the body. Bone, liver, brain, wherever, breast. And they're oval in shape, and they're usually spread diffusely throughout the lungs, so they're all over the place. Yes, Dana?
Does anything cause this more than the other?
No. This is I believe small cell is more genetic, but there's a kind of an idea of how it just looks like fatty tissue, but it's actually these small. Higher risk, yeah, absolutely.
My dad had small cell, and of course he smoked his whole life, but he didn't really have any symptoms until he was diagnosed in the end of August and died the beginning of November. But he had no
symptoms.
He had a little high blood pressure,
And part of it may have been too, being a smoker, he just attributed a lot of stuff to just, well, I smoke and I have some lung problems.
It was just, weight loss and, that,
but it was a rapid deterioration. And that's classic for small cell.
That was, when they said small cell, I was like, oh, small cell, I bet
That's better.
And then, they said, no, it's
Yeah, that's the worst you can get. Yeah, right. Just the fact that it's so rapidly growing that it occupies lung volume and obstructs the process. Again, 87% cancers due to cigarette smoking. I don't know if that has changed or not, but greatest incidence again with small squamous and adeno and going from there. But you can also have some occupational exposure that can cause the same kind of a problem. Now, I'm not going to have you memorize this or do anything stupid like that, but I do want you to understand this concept that how we stage lung cancer, or really stage all cancers, is based upon three things. The size and type of tumor that you have, that's the T, because it's the TNM method. N has to do with how much association you have with lymph nodes. Are there lymph node involvement? Then it's a further stage than if there's none. And metastasis is that cancer showing up somewhere else other than their primary source. Reason why this is important to stage it is because it gives us an idea of survival rates and therapy that can be applied. You have a handout in the back that goes through this process. You don't need to memorize it. I'm not going to give you a bunch of clues and you tell me what stage the cancer is at. That's just too crazy. But obviously stage 0 is very early on, with stage 4 being very, very late. And you can see that stage 1 and 2, and 1 and 2 are both broken up into A's and B's, as is stage 3. You can get surgery with or without chemotherapy. Stage 3, you're basically looking at not only chemotherapy and surgery, but you're also maybe looking at radiation therapy. 3B is radiation therapy with or without chemo, and stage 4 is chemo, and there's nothing much else they can do.
So the stages have nothing to do with where it's metastasized to. I think
Not necessarily, no, but the fact that it's metastasized puts it into a higher stage. Right. Correct. Correct. But it's also telling us how aggressive it is. So no problem. That's the worst. Yeah, 'cause stage 4, you basically have limited options that you can end up doing. This is basically looking at the T's, the N's, and the M's, and where they fit into the grid. Just know what the T, N, and M stands for. Tumor, node, metastasis. Okay. So here's an example of a stage 1 disease, very isolated, what we'll often call a coin lesion, because it looks like a coin on a chest x-ray. And now it's getting more progressive, more aggressive, more aggressive, and now it's occupying the lymph nodes in the process. That's out of Desjardins. That's for large cell. Okay, small cell really is 2 stages, limited and extensive. And again, chemotherapy is your only therapy for it, and as Teresa pointed out, survival is not long. It's not something where you can survive long term.
Radiation, but I think that was like just palliative, like to
Shrink the size of the tumor. Looking at 5-year survival rates from lung cancer, stage 1, pretty decent, not as good as breast, but pretty decent. But as you get further and further along, you can see that, I mean, even stage 3B breast cancer, you still have a 50-50 shot having a 5-year survival rate, but you have less than 5% in lung cancer. It's a very aggressive, and in answer to your question, Lauren, why the survival is so poor, it's because it's diagnosed so late in the process. Just like COPD gets diagnosed, this gets diagnosed very late also. From a pulmonary function standpoint, you're looking at an obstructive element and possibly an obstructive element, or both. Depending on the location of the tumor itself. It's more centrally located, obviously, don't affect the airways. Other symptoms, again, 25% are asymptomatic, but you will see typically cough, hemoptysis, and weight loss are the big ones that you'll end up seeing. In severe cases of hypoxia, when there's severely hypoxemia, you'll see the coin, but that's usually around. We talked about coin lesion. And that's just an example of a solitary pulmonary nodule. There's one spot that just happens to be growing. It's often irregularly shaped in the process because of the obstructive element, or there's invading normal tissue. You'll have some consolidation present. Because of the lymph node involvement, you may end up with pleural effusions. And it can involve mediastinum, and the structure is located within there. And usually by the time you're seeing it on a chest x-ray, the size of it is large enough that it's become into the invasive stages. You can't see this really well. There's a big tumor right there. That's why the arrow is pointing at it. You can't see that. Some other non-respiratory functions. Such in the mediastinal involvement, there's a nerve that runs in the mediastinal space that innervates the vocal cords, and it's called the recurrent laryngeal nerve. When that nerve becomes damaged, you end up with vocal cord paralysis hoarseness as a side effect. Can also have some problems with esophageal obstructions and difficulty swallowing. You don't need to worry about Horner syndrome. There is something called superior vena cava syndrome, where the vena cava doesn't drain blood flow correctly from the head and upper body because of the presence of tumors in the mediastinal area, and all kind of other stuff. Diagnostic testing, we would use chest x-ray as one of the ways to diagnose and identify it, although CT scan and other types of radiology scans are becoming a little bit more prominent. We can do bronchoscopy, including a transbronchial needle aspiration. Doesn't that sound like a fun time? Going under fluoroscopy guidance, going through the bronchus and sampling the tumor. If the tumor is just adjacent to the bronchus, we can get a sample without having to go into actually doing surgery to obtain one. You can also go from the outside transthoracically, doing a small needle biopsying process. We can look at the pleural fluid. Remember, this would be an example where you might see an empyema as opposed to, not empyema, excuse me, an exudative pleural effusion in the process. And again, looking at the cytology and sputum culture. There is also PET scanning, positive emission tomography, which basically uses a substance called fluorodeoxyglucose, yeah, whatever, Rick. But basically, what I want you to know about this is it's a substance we can give that is drawn to a tumor because of the high metabolic activity of that tumor. So it's very easy to identify the location of these cancerous tumors. And because the malignancy has a higher uptake of this and a higher metabolic rate, you're going to see it much more prominently than benign tumors. Hopefully the tumor can be identified early enough and staging early enough so it could become curative. Otherwise, the term that is used is palliative, which means we just do what we can to relieve symptoms, relieve the pain, relieve the dyspnea involved. Radiation is, again, attempt to try to kill the tumor. Sometimes the treatment is worse than the cure, Give an example. I have a friend whose wife had non-Hodgkin's lymphoma of the stomach, and the medication that was used to treat the chemotherapy agent actually led to her heart going into heart failure, and her ejection fraction was like 18%. So cured the tumor, damaged the heart. And you'll see that a lot with lung cancer. Sometimes the radiation's worse. Lung resection, we can remove a portion of it. What we call a wedge resection, where literally it's a wedge of the lung that is removed. We can remove an entire lobe. We can remove an entire lung. Obviously not bilaterally, but we can certainly do one of them there. But again, not a lot of the patients are candidates for surgery simply because their pulmonary function is so deteriorated. Chemotherapy is what we primarily use to kill the cancer cells, but again, has also problems associated with that. And then there's some other experimental therapy that's always on the outside there. I would like you to know that less than 35% of FEV1 predicted is considered a contraindication to surgery. And no anesthesiologist is going to want to take you into OR when you don't have that kind of a function. So you're left with radiation and chemo and some of the other therapies that are out there. Our primary involvement for these folks are, again, oxygen protocol, bronchial hygiene protocol, perhaps some hyperinflation protocol, depending upon the size and the location of the tumor. Remembering that these also have altered immune systems, especially when they're on chemotherapy, so they'll be in a protective isolation with a private room. And obviously, there's anybody who has studied Kubler-Ross and psychology know about the 5 stages of death and gripping the transition, the denial, bargaining, depression, and acceptance.
Joe chemo, load that one. That's what do to you. Okay, I'm gonna stop there. Thank you for allowing me to continue on a little bit more.